HIPcast is brought to you by Enterprise Social Record.
Well, hey, we have an interesting treat today for me. Harv Sanders is joining us. He is not a health information professional, but he does lead them. He is the CFO at Rhea Medical Center, which is a critical access hospital in Southeast Tennessee. And he used to be my boss. So he's Harv, formerly known as my boss. Harv, welcome to the show.
Hey, Shannan and Seth. Yeah, I think you're right out of, I don't know, middle school or something. It was back when you only had one set of initials after your name or something like that.
Yes,
So yeah,
I
it's
had
been
one
a
set.
little while. Yeah.
One set of initials. I'm not sure how many I have now, but it's a lot. So, and Harv has been at Rhea Medical Center for 25 years. Harv, is that right?
Actually, yes, 25 will be 26 in 2 weeks, actually.
Okay. Well, happy almost anniversary. And
Thank
today
you.
we're going to talk with Harv about some of the pressures in healthcare, specifically for a critical access hospital or a rural hospital. We're going to talk about the value that CFOs see in the HIM professionals. So, still a very relevant conversation for our audience for sure.
Yeah, absolutely. And one of the things we normally do with our HIM guest is we say, well, tell us about your HI journey. Well, you're a little special. You don't have the HI journey, but share with our listeners and our audience how you kind of ended up getting into the CFO world, especially because we do have a lot of students that I think would probably be interested in maybe going that track in their career.
Yeah.
So tell us about your journey.
All right. Well, I have an accounting degree. That was my background. Was in accounting. I went to UT, then went to work for a CPA firm out of college, and my goal was to get my CPA license. And to be a CPA, you have to work in a CPA firm 2 years and pass the exam. So that was my goal, was just to get my 2 years in and get the exam and get out. Public accounting just wasn't for me. It was a good learning experience because you got to see a lot of different industries, and I tell anybody I know in accounting that you should probably do that, and especially go into auditing, and it gives you a good view of different industries and gives you an idea of what you want to do. Unfortunately, when I was doing auditing, I never did a healthcare audit. I was more manufacturing and financial institutions. And so, but one of the things I did was a program that kept up with capital equipment and depreciation. And once I got my 2 years in and had the exam under my belt and the license, I saw one of the local hospitals in Chattanooga, had an opening, and one of the things they listed as a requirement was that specific software program. So, I did have a couple of nurses in the family, so I guess that was a loose connection to healthcare. And, so I went to work, at the hospital, and it was part of a large for-profit chain, and it was a really good opportunity, and I moved around with them a little bit, and after 7 years of moving around, this actually I went out of healthcare for a little bit, and this came open, and it was close to home. I grew up in Chattanooga, and came here, and it was a real learning experience. After being with a for-profit, you didn't really have to worry about cash or anything like that. And I got here, and it was my very first or second day, and the AP clerk comes up to me and goes, "Hey, can I write checks?" I'm like, "What do you mean, can you write checks?" "Yeah, you can write checks." And it was never a thing. Well, come to find out, we had 2 days cash on me. So that was something I didn't really have to know a lot about cash flow working where I did for the large corporation. So, that was kind of crash, learning course on cash flow and how important HIM, and I already knew the rev cycle part, but it made that from a not as major a focus to the primary focus of every day. So
we used to laugh at our health system and say we're not for profit and we can prove it.
That's definitely us.
It's going to be his new tagline. He's probably going to say that to Hoss today.
I'm going to use that. Yeah.
You mentioned the accounting degree at UT, so I'm a UT grad, obviously.
I like your background there.
I appreciate that. Yeah, I grew up in Knoxville, so that's the way it is. But I thought when you said that, my immediate thought was, man, I bet that's a fun group, the accounting majors on campus. Just wow.
It was a wild group, Yeah.
I bet
it kind of reminds me of your story, Seth, about how you happened into HIM, about being in the fishbowl.
Yeah, it was the spam can. If you probably remember the spam can, It was the old building there on the business campus. I was in finance.
You remember why it was named the spam can, don't you?
I mean, I thought I was told it was because it looked like a big spam can.
That's exactly it. Okay. That's what they told you on the tour.
That's it. Yeah,
a spam can because it looks like a can of spam.
That's right. That's a blast from the past. That building's gone now, unfortunately.
Yeah.
Which,
it's
all very different.
I'm gonna steer us back, but it's funny that you're both UT grads. It's just many years apart because Harv Seth is younger than me, and you are just this much older than I am. So Seth is younger than both of us followers.
Yeah. Actually, I mean, people on the podcast probably don't want to hear this, but you gave me a real existential crisis. Because you probably don't remember this conversation. I can't remember why you reached out and asked what I was doing. I was out camping in the desert by myself and doing these hikes, and you're like, "Why are you doing that?" I guess I'm having a midlife crisis, and your response was, "Are you planning to live to 104?" And I was like,
I do remember. I do remember. Yes,
that was really really hurt. So.
just keeping you humble, buddy. Just keeping you humble. That's all. Before I ask the next question, I do want to give a little bit of a rundown. You all have come a long way from 2 days cash on hand at Rhea Medical Center. When I was there, we were licensed for 25 beds, critical access. We finally got a couple of swing bed license, I think. There was a nursing home attached to us. Now there's a new facility. This has gone from a very old 1950 or 60 something hospital building to a modern, beautiful, still a critical access, still small, but the ancillary and outpatient services and the clinics that Rhea Medical has expanded into ownership of around the county, pretty significant. So I don't want you to give out any conversation or any details about the hospital that you shouldn't be sharing publicly, but I just want to commend you on being part of that journey for 25 years, where we went from 2 days cash on hand to now having, not that you don't have constraints, but you've been there for the build of the new hospital. You've been there for the medical office building. You've been there for adding the chemo and infusion services. I mean, there's a spinal, maybe let's talk about the spinal procedures maybe that you're doing. I think at least you are the only one or one of two hospitals in the nation doing this particular procedure. So before we move into the real reason for the discussion today, just talk a little bit about that. I commend you and the team at Rhea Medical Center, plus the community, for the growth that we've had.
So you're right. I mean, we've been very fortunate. The journey we were on from where we were to building. I think the new facility opened about 7 years, after having 2 days cash on hand. So, and actually, we weren't critical access at first when you were here. We actually converted to critical access.
Right.
So we actually reduced the number of beds to become critical access. So, that helped us along the way. And, like you said, we've added some services, and the latest one is the spine program. And what is great about it is the focus of the spine program here is motion preservation. So, most of spine procedures in the past have been fusion, and if that's one of the things you always hear is you never want to have back surgery, and I've known people that were never the same after a fusion. So we were fortunate enough. There's a hospital in Colorado that has a spine program, and Chattanooga has Dr. Hodges. He is well known in Chattanooga.
Mm-hmm.
He is really committed to this spine range of motion preservation, and he's with a company, and they're actually working on an implant, but there's already an implant out there, and from another company, and we've been doing. We started doing cases in September of 25, and so we've been doing cases. And what's exciting about this is we're a small critical access hospital, so we don't have a large market area. It's basically the county, and little fringes on the outside of the county. And with this program, we've had people travel from Pennsylvania, Iowa, Alabama, some from the Nashville area. But one of the and this is bad. We actually lost this patient to a different hospital for the procedure, but there was a patient from I think it was British Columbia, and we actually lost that patient to a hospital in Germany. So it's just amazing to think that
That's
with this
amazing.
little hospital in Southeast Tennessee, we're usually worried about Chattanooga or Knoxville, patients going there, and here we are, losing a patient to a hospital in Germany. So yeah, it's been really exciting, and hope to see it grow. And one of the exciting things about it is when this implant gets approved, we're going to be an actual teaching location where they're going to train surgeons on the implant.
Yeah, that's incredible. I mean, that is so incredible for a critical access hospital. It is. It is just it's an incredible way to. Your inpatient is going to be what it is. It's going to be a critical access hospital. Currently, it has to be that way to sustain, right? But that doesn't preclude you or limit you on outpatient or ancillary or other types of service. It's amazing. I mean, it is amazing what all has been happening there. And so I do want to kind of point to the fact that you mentioned Rhea Medical wasn't a critical access hospital yet. I'm not even sure if the designation existed yet when we first started at Rhea Medical, Harv.
Well, I don't think we're that old. I think it existed. It just wasn't really well. I mean, it really wasn't growing at the time.
Oh my goodness, that's pretty funny.
Yeah. So it actually predated us.
Yeah, well, that's good to know. That's good to know. Some things barely did. DRGs only predated us by a few years because that was like 1984 or 5. So, well, let's talk a little bit about the high pressure elements in the revenue cycle for healthcare, and speaking specifically from your lens of being at a critical access county owned hospital. What are some of those high pressure elements of the healthcare revenue cycle today?
For us, it's definitely right now it's denials. We're a small facility with a small staff, and you're dealing with the Uniteds and Humanas and Blue Crosses, and pretty much unlimited resources, and they're using AI, and we're expected to kind of do battle with them over these denials. And it's gotten to the point where even they're going back almost a year, and we're seeing cases where there's even been a peer-to-peer in the past that the physician from the insurance company approved, and now the AI is coming back and to overturn it. So, the issue is, we have limited staff, and I mean, it's just a constant, stream of denials that you're trying to battle. And so that's definitely number one. Another big issue is Medicare Advantage has just really kind of taken over. We were about 55% traditional Medicare pre Medicare Advantage, and here, right now we're about 31% Medicare Advantage, about 24% traditional Medicare.
Wow.
So you're dealing with a lot more in the rev cycle, having to get offs, and then on the backside more denial issues.
Wow, I didn't realize that had that kind of an impact on your Medicare percentage population, because Medicare Advantage essentially functions like commercial, right?
It's definitely like a commercial.
Yeah, more like commercial than Medicare, right?
Exactly. You have to jump through all the hoops, and a lot of people, a lot of your patients, when you tell them, this isn't approved, they think they have Medicare, but it's like, it's really it's more like a commercial insurance.
That reminds me of an episode we did with Mississippi, a lady. Well, her name's Lori. I call her Mississippi, but we
actually saw this episode.
Yeah,
Okay.
She did an episode on that of the difference in trying to educate. It sounds like there's just a massive education problem amongst the older population of whether or not they need an Advantage program or traditional Medicare. And honestly, it's the more I hear about it, the more I learn about it, especially even with my mother. It's a little bit of a well, it's not a little bit of a problem. It's a major problem that the insurance companies are targeting these folks for advertisements to get them onto these plans and away from traditional Medicare. And that's a problem. That's something that probably should be elevated up from a congressional perspective to be looked at legislatively. Just random things thrown out there.
Yeah, definitely. I'm sure as probably where you were. I know it's here in Dayton, but when MA was really growing, they would have dinners at a local restaurant where they would try to get potential enrollees, and even now you have these people that are out there advertising as Medicare specialists, but I mean what they're really doing is getting you to sign up for Medicare Advantage, and I think I've heard they get anywhere from $700 to $900 per person they sign up. I can't say that's true or not, but that's kind of what I've heard. So yeah, there's definitely financial incentive for people to be switched away from traditional Medicare. It's one of those things. If you don't, if you're 65 and healthy, maybe that's okay, but when they're trying to sign up 80-year-olds with a lot of health issues, it really, I think, becomes a kind of an ethical question of whether they're doing the right thing or not.
Yeah, what is it called? Predatory marketing?
Exactly.
Typical terms.
Yeah, they have no understanding. They have no understanding of it. The recipients or beneficiaries have no, generally speaking. Now, I don't mean the whole population, but generally speaking, my dad's 86. Both of you know that I help take care of my dad. I'm a daddy's girl. And so he's 86 years old. And when it comes to his health coverage, he has no idea what is the best. And so 15 years ago, I moved him to a Med Advantage plan because he was on a blood pressure medicine and something for reflux. And then he just graduated to more and more things and had more and more needs. 78 years old was the first time he ever spent a night at the hospital, and it was at Rhea Medical Center. He was born at home, y'all. So he had never spent the night at the hospital until he was, and it was at the new Rhea Medical's new facility. And then a couple years after that, my daughter-in-law, who's a physical therapist and director of a rehab at a long-term care facility, she said, you've got to get him off of Med Advantage, because when it comes to any long-term care needs, Med Advantage will not have the same longevity of treatment options that traditional Medicare does. And so we moved him off, but for a period of time, Medicare Advantage was great for Dad because he had that in a drug plan and it was wonderful. Like that was all included and it was affordable because of his health. But when your health risks change or your circumstances and conditions change, you've got to decide if you're aligning with the right type of plan. And most Daddy doesn't know.
Yeah.
And I won't say most folks are generally speaking, but unless you've been, I'm in healthcare for now almost 29 years, and I still don't understand everything. Like, I don't think any of us can. It gets so crazy. So
And
it's
imagine the patient's
challenging.
perspective being even worse. And I was thinking about the denial conversation Harvey mentioned being number one challenge. And I see things on Facebook, which is older people on Facebook is one of the most dangerous things in the
Yeah.
world. But I see people, especially around my health system, saying, "Oh, they're just gouging us. They're trying to get all of our money." And I'm like, part of it is more the insurance company and the
Yeah.
fight that the health system's having to go to, not only to get paid, but to stay paid because that money's getting taken back up to a year afterwards, even after the approval's been done. And that's something that the patient population needs to understand is you guys are fighting for the money a year later.
Right. Like I said, we have limited resources and, when you guys go to conferences, going to more financial stuff and I guess, I don't know if you see this at the conferences you go to, but, the large one I go to, has thousands or however many vendors and they're all related to rev cycle. And you're like, it should not be that difficult where there's that much, demand and companies trying to, help this fight with the insurance companies. But I mean, it's just fighting with the insurance companies is just pretty much a whole industry into itself, which you think, I mean, how much is that adding to the, to our country and the cost of healthcare? It's ridiculous for everybody. It's not good for the patient or the country as a whole, I don't think.
Yeah, I would say at our conferences, we have release of information and revenue cycle is almost all we have, right, Seth?
Right. Yeah. That's the primary. And I always try to put it into an analogy that I can understand because I'm a simpleton. But, it's like having somebody mow your yard. They come by and say they'll mow your yard for $50. And it's like, fantastic. All right, go mow it. And they do the service and they bill you. And you say, well, maybe you didn't need to weed eat around the house, and I'm only going to pay you $25. And you spend the next year fighting back and forth on what that is. And that's what hospitals are doing thousands and thousands of times for every patient encounter against multiple different insurance companies. That's a massive hill to climb.
It is. It's a huge burden.
So we're here to talk about some of the HI folks because that's what we do. Shannan and I, we collect letters behind our name. That's what we do in the HI industry. I don't know if we're hoarders, but we are collectors of letters behind our names. So what do you see as the value of your HIM team? And for that HIM audience out there, this is a great understanding of how a CFO sees us.
Yeah, well, I mean, it's such an important piece of everything. And, being honest as a CFO and with my background, I mean, HIM is probably the most foreign and kind of mysterious area to me, to be honest.
Mysterious.
Because,
I love it.
I have, the accounting background, which, accounting reports to me, business office, that's still pretty common, that you're in business and even the audits I did coming out of school, I mean, you deal with stuff like that. So that's nothing unusual. Materials, that's supply chains, all pretty easy to understand, and IT, use that every day. But, the HIM piece of it is so different because you guys are dealing with the clinical side that, I have some understanding, but I'm not a clinical person, so I'm more of a numbers person. So you guys are the piece that kind of links it to the business office, the rev cycle side. So of all the areas, I would say health information is the one where I have to rely more on the knowledge and expertise than the other. It's not just something I can jump in and start digging myself and try to figure out because I would have no clue. So I really have to put a lot of trust in what they're telling me. So it's it's very important. And, it's changed a lot over the years. We were joking earlier about how long we've been in this, but back when you started, Shannon, I think we were still calling it medical records, and still had that
It's true.
image of your more charts and not really the importance of it. But like right now, hitting back on the denials. I mean, HIM's where it all kind of starts, because if that documentation's not there, the coding's not accurate. That's such a main piece. And then when we do get denials or audits, those are the guys that are going to have to kind of be our defense there. So it's just a huge importance to us in the rev cycle and cash flow. And then the other pieces that you don't really think about outside of what it's doing with the rev cycle is we use it for other areas like some of the information that comes from HIM is what we use when we're looking at new services.
Yes.
So that's very important that we can kind of see maybe what's the market, or like if we're seeing, hey, we're doing a lot of these tests in the lab, that might mean that there's a lot of cancer in the area, and hey, maybe we should try to have an oncology program. And so that played a decision when we went with starting the oncology program a couple of years ago, was information that came directly from our HIM department. So that plays a key part. And then it's also a good check when, like, every month we meet with the department directors and have like an operation review of the department. We talk about their financials and their quality measures, and just what's going on in the department. And one of the things when we're talking about salaries is, like, we'll say, looks like your volume was down, but your salaries were up. And the response is, well, yeah, but the patients are sicker. They're a lot sicker than they were. And what I always do is, if it's inpatient, I'll look at the case mix index that comes from HIM, or if it's like ED, I can say, well, the visit levels don't reflect that.
Right.
So there's areas that we use the information that comes from HIM that's just not readily apparent as the rev cycle, but it's very important in a lot of decisions that we make.
Yeah, I appreciate you saying that. First of all, had I known that you had to rely on us that heavily, I probably would have been a little smarter about what I asked for when I worked for you. That's
Salary
probably,
wise?
yeah. Oh, yeah, absolutely. Not just salary wise. Those are the things I wanted in the department. But definitely salary wise. But I do.
I forgot that on a challenge. That was one of our challenges, was salary. So,
And salaries are a challenge in rural areas. I mean, especially, I don't know, have you, like, I don't want to get into this as a side rail conversation, but the certificate of need that just got removed from law or requirement in Tennessee, it's going to have an impact on rural hospitals across the state. There's almost no way it couldn't, so that's going to be a new challenge to face. But I really appreciate the strategic decision making based on the data that is really codified in healthcare, or in your medical records and in your systems, information systems, by the HIM department. And it's not just the codification, right? It's not just the diagnosis and procedure codes or the revenue codes that come from the business office. It's also the completion of that medical record and the appropriate documentation. This is specific to your denials. Did that H&P get on? Was it there in the appropriate, whatever the statute says, it has to be in there? Is all of the documentation complete and signed? Do we have a culture that lets us add the diagnosis related to that? And even your queries, are they query compliant? So I do appreciate the strategic driving. It's just not the codified language though, because the health information department is that, but it is part of revenue cycle. But the chart analysis that's done, the completion of charts, even down to is your medical staff, I don't know what you call them now, coordinators, people that write the letters, are they still in the health information
They
department or have
are.
they moved? Okay, yeah.
They
So
are.
there's
So
even
there's
physician
all right.
interaction from a perspective of keeping them on track for the DNFB, right?
Right. So yeah, HIM does so many different, being smaller, you're going to wear more hats. So you're
Yep.
right. I mean, they handle a lot of the medical staff and the med staff bylaws. So a lot of that is handled in HIM, and then you have the other issues or other areas like privacy officer, HIPAA, all kind of resides there.
Yeah.
Watch.
Yeah, I would not enjoy that part, the privacy officer part.
I mean, we're truly the hub of the wheel. I mean, that's what you've described from the CFO's perspective. At least that's what we were told in school, and that's what we believe. But
No, it is, and like I said, I mean, it's come such a long way from just being viewed as medical records and charts. There's a lot more value there that is brought from the department. It's just not always seen. Like I said, some things you wouldn't even think about how we use it sometimes.
Well, Seth and I have this rule, and it started last year in 2025, that you can't have a healthcare podcast without saying the AI. So I'm curious, not necessarily where you're using AI in any of your systems, but more around are the health information professionals that you have part of the discussion around governance around AI that you're going to be using if you're not using it now, which by the way, had dad in the ER up there the other night, and there is definitely ambient listening happening. So I didn't know if you knew that.
Yeah, no,
Surprise.
actually that's something we just rolled out and testing, but yes, there's, definitely a concern with the information. So yeah, that is with our privacy officer. So, but yeah, no, AI is one of those things. I mean, I don't, I think
It's okay to be honest. Seth is also my Eeyore, so I'm just sitting in the screen between two Eeyores here.
No,
It's fine.
So you're the Tigger or something here.
I'm
Yeah.
definitely the Tigger.
She has all the energy.
So, I mean, I'm a huge believer in AI. I mean, I use it quite a bit. If you get an email from me, it's probably AI. But no, I use it for a lot of analysis personally. So
That's
I
good.
have a good belief in it. But earlier you touched on salaries, and one of the misconceptions is that, oh, you're a hospital, you're making all this money. Well,
Yeah.
most critical access in rural hospitals are either losing money or just break even. So,
Yep.
one of the things that happened with COVID, as you're aware, salaries went crazy, and just like in the past, like we'll use Shannan for example here. I mean, we lost Shannan to a hospital out of town,
Mm-hmm.
and so that was our competition in the past was, close by hospitals, the larger hospitals in Chattanooga. We were competing for staff. when COVID came along and there was remote working, all of a sudden we're not competing with Chattanooga or
Yeah.
Cleveland. We're competing with California. I mean,
Mm-hmm.
and so, it's just no way to compete. So, I do think at some point with AI, we might have to rely more on AI just because we can't get the people. It's just such a shortage of coders anyway. I think that kind of happened. You mentioned the ambient listening. I think that kind of happened with transcriptions.
Mm-hmm.
I mean, that was just something where people weren't going into transcription. It just got harder to find people, and then you had to outsource it. And now. So I think if it keeps on this trend where people are working remote and they're working for companies that want to charge you twice as much, to code something as you could, hire somebody. I think at some point people are going to turn to AI. Now, I think the one factor that could hinder that is, what we tend to see is, everybody has this great technology, but they want this, really high price tag for that technology. So if they keep the price tag really high where it doesn't if they're going to charge you the same as some outsourcing company to do the coding, I mean, there's no benefit. So
Right.
So I think there's always going to be a need for coders, and I do think at first it'll be more of a review thing, but I think this where everybody thinks that AI is not eventually going to take over. I just don't think they've used it a lot yet to see that eventually you're gonna need higher level people, but I do think it's definitely going to take away from entry level. Because I think back when I came out of college, the entry level stuff I was doing, I mean, you could have AI do that now.
Yep.
And I think that's what's going to happen. So I think you need to kind of get as front of the curve as you can, and and then hopefully be on the right side of it.
Yeah, and that's what we call, or we call that having the expert in the loop. And I agree. Maybe the most advantageous place for AI in healthcare is at those entry level administrative tasks that we don't really have to do because they're redundant and they can just be repetitive and done by the machines, right? But that doesn't take the skill away. And then maybe your health information professionals, especially the coders, maybe they're reviewing an output from AI at some point, if you ever get there, from coding ERs through autonomous coding or whatever it is. There's a review process, but then also they need to upskill as health information professionals to help learn and be better at doing the data analysis and the visualization of that data, which can still be done with the AI tools if they have access to those. So
Right.
I see it. I agree with you that entry level coding is going to be really hard to make any money. Like you're going to be at a minimum wage job if you're an entry level coder because you really need those higher skilled people.
Right. And that's the worry. I mean, how do you get to be higher skill if you don't have that firm
Yep.
foundation that you get from the coding in the first place?
A lot of these college students are booing when anybody mentions AI in their graduation at this point.
Yeah.
Right. So, but yeah, I definitely agree. I mean, there's so much information that the analysis and being able to digest and use that information, that's where I think where the future of the actual human worker is going to be.
Yep, that's fantastic. Well, this has been a great episode. It's been a great. It's interesting for me to hear the perspective from a CFO on the HI industry and just the industry as a whole, because it's a challenging environment in healthcare. It's a challenging environment amplified when you're in rural healthcare and critical access hospital. But it sounds like you guys at Rhea Medical are a shining light in how to go out and find
It's really
other service
impressive.
lines. So it's been a pleasure to have you on HIPcast, Harv. Thanks for joining us.
Well, thanks for having me. I enjoyed it.
Absolutely. Shannan, until next time, my friend.
We'll see you next time, buddy.